Good evening and a very warm welcome to all of you to this fifth executive SFF webinar. And this is under the guidance of the executive committee led by our very dear Dr. Ashok Khurana sir, Dr. TLN Praveen sir, and Dr. Bimal Sahani sir. And Dr. Vandana Chadda and myself are the coordinators, and we are really thankful for this opportunity. The topic for the webinar is congenital diaphragmatic hernia. Way back in 1679, when Riverius for the first time discovered CDH in a postmortem case, there have been much advancements in the field of antenatal care, diagnosis, interventions, and postnatal care. So today we have very eminent faculty at the national level, as well as we have our FNB trainees with us, and they will also be part of the presenters. And I'm really sure that we are going to look forward to some great academics. We will be tracing CDH right from its conception, embryology, anatomy, the genetic associations, and of course, the advancements which have happened in this field. Now, may I request our visionary legend, Sir Dr. Ashok Khurana, to share a few words of encouragement and give us his blessings for the success of this endeavor.
Thank you, Sumitra, and my congratulations to you and Vandana for putting this together. It's a fantastically crafted webinar and brings us up to date. I know it will do so very abundantly on this topic that has been fairly controversial so far because of the delay in the results of the Fetal trial. We do know that in 2003, when Michael Harrison first published a mixed population, the trial had to be closed before time because it had a very poor selection criteria. And we thought that the Fetal trial from the Leuven group in Belgium, along with the associate centers, will really do something for us. But it took ages and ages and ages. And the tragedy was that we never got answers and they kept asking for more time. And then we couldn't do Fetal outside the trial, which I think was the biggest scandal that we have ever seen. But well, we persisted and we were patient with Jan Deprest, and he's come up with some very interesting findings, some that tell us not to be so happy and some that tell us that we can be happy sometimes. And I really look forward to you clarifying all of this in the webinar today. Congratulations once again, and back to you for the rest of the webinar.
Thank you so much, sir. And we'll start the session. I'll just share my screen, and I would just like to, is my screen visible?
Yes, ma'am.
So I would just like to introduce the presenters and the faculty for the first half of the session. And these are our FNB trainees will be presenting the first three talks, Dr. Suchandana Dasgupta, Dr. K. Shravani Reddy, and Dr. Anna Fatima. They are our FNB trainees in maternal fetal medicine at VMMC and Safdarjung Hospital. We have very eminent faculty, and we have been mentored for this webinar by Dr. Krishna Gopal himself. He's the National Secretary, Society of Fetal Medicine, and he has many accolades to his credit. Vandana Chadda and myself, we are the coordinators, and Dr. Vandana Chadda, we know very well. She is very well known in the field of medical genetics and also in the field of fetal therapy. She, of course, has, she's a genius from childhood, and she has many accolades and achievements to her credit, and her area of interest being fetal therapy. Myself, I'm working as a professor and senior specialist at VMMC and Safdarjung Hospital. And I'm also faculty at the Fetal Medicine and Genetic Clinic, and we are offering interventions as well as invasive procedures at our hospital. For the first talk now, which is on time travel through black holes, which will be presented by Dr. Suchandana Dasgupta, I invite our expert, Dr. Neeja Gupta. Dr. Neeja Gupta, madam, is additional professor at the Division of Genetics, Department of Pediatrics, All India Institute of Medical Sciences. And she's a very well-known teacher in the field of medical genetics. She too has many publications and book chapters and multiple academic achievements and awards. And her areas of interest are management of inherited metabolic disorders, genomics of intellectual disabilities, skeletal dysplasia, and dysmorphic syndromes. Welcome, Dr. Neeja Gupta, madam. I'll stop sharing and I'll invite Suchandana to share her screen.
Thank you, ma'am. Are my slides visible, madam?
Yeah, visible. Please go ahead.
Okay. So, very good evening to everyone. I'm Dr. Suchanna Dasgupta, and my moderator for this talk is Dr. Nirja Gupta. We'll be discussing the basics of congenital diaphragmatic hernia, which is the topic for today. So, we'll be discussing the definition, anatomy, embryology, and related genetics. So, what is a congenital diaphragmatic hernia? It is a developmental defect starting at 6 to 10 weeks of gestation due to partial or complete absence of the diaphragm. It leads to herniation of the abdominal contents into the thorax, which results in decreased bronchial branching, the decrease in alveolar number, and pulmonary vascularization, which eventually leads to pulmonary hypoplasia and pulmonary hypertension, which is the sole cause of the morbidity in these fetuses. The incidence is 2.4 to 4.9 per 10,000 live births. Most of the cases are left-sided, and 10% of bilateral CDHs are being reported. In cases of fetal demise, the incidence of bilateral CDH is quite high, 27%, indicating that it has the worst prognosis. Now, diaphragm is the dome-shaped structure separating the abdomen and the thorax. It consists of that central tendon, which is a centrally placed cartilaginous part, and a peripheral part that has the right crura and left crura. It has a muscular part. This part is attached in its periphery, and anteriorly it is attached to the sternum to the xiphoid process. In the lateral, both lateral side, the costal part is attached with the internal surfaces of the lower 6 costal cartilages and their adjoining ribs. The lumbar part, that is the posterior part, is attached to the medial and lateral arcuate ligament and the crura. Now, there are 3 major openings and few minor openings in the diaphragm. First one is the aortic hiatus, through which the aorta and thoracic duct passes. The azygos vein and the hemiazygos vein sometimes passes through it, and it is situated at the 12th thoracic vertebra. Second is the esophageal hiatus, through which the esophagus and vagal trunks and esophageal branches of the left gastric vessels pass, and it is situated at the 10th thoracic vertebra. Third is the caval hiatus, through which the inferior vena cava and branches of right phrenic nerve pass, and it is again situated at the 8th thoracic vertebra. The minor openings are the azygos and hemiazygos vein when they don't pass through the aortic hiatus, and the greater, lesser, and least phrenic nerve pierces the diaphragm to enter from thoracic to abdominal cavity. Now, coming to the embryology, diaphragm is mesodermal in origin. The different parts origin from different embryological origin. Here it is shown in the color-coded and number-coded form. The septum transversum gives rise to this central tendon, that is the central part. And it is depicted here in the green color. The pseudoperitoneal membrane and the peripheral body wall muscle give rise to the muscular part of the diaphragm, which is depicted here as the number 2 and number 3. And the mesentery of esophagus gives rise to the crura of diaphragm, depicted here as the number 4. Now, sites of CDH, as it's originate from different part with resulting from fusion of different origins, it can be either anterior, posterior, right or left. The posterolateral left-sided hernia, that is the Bogdalic hernia, is most common. Now, the pathogenesis of CDH is it develops due to failure of normal closure of the pleuroperitoneal folds during the 4th to 10th week of conception, and it allows herniation of the abdominal viscera into the thoracic cavity, which interferes with the normal lung development. There can be either failure of fusion or can be a primary defect. Now, quickly coming to the types of hernia. First is the Bogdalic hernia, which is the most common, consisting 85 to 90%. It can be right or left. Left-sided Bogdalic hernia is the most common, present in 80%. Second type is the Mogagni, which consists of 1 to 2% of all CDH. It is situated anterior between the costal and sternal origin of the diaphragm, and 90% is present in the right side. Now, there can be congenital absence of the diaphragm. One side of the diaphragm, that is the hemidiaphragm, can be absent, and it has a poorer prognosis. septum transversum defect can be there, and I have already mentioned it gives rise to the central tendon, so the defect will be placed centrally in the cartilaginous part. Now coming to a brief discussion about the genetics, majority of the CDHs occurs sporadically, that is there is no identifiable familial link. Chromosomal anomalies are present in 10 to 20% of cases, most common being the trisomy 21, 18 and 13. Non-chromosomal syndromes are present in 10%, French syndrome being the most common, and overall associated anomalies are present in 40 to 60% in live-born fetuses, whereas if there is intrauterine demise already, 90%, 95% of cases, there is presence of associated anomalies. And the recurrence risk of isolated CDH is reported to be less than 2%. It is rare but present due to multifactorial inheritance. The genetic defects can be caused by aneuploidies, deletion, duplication, translocation. It can be a de novo mutation, polygenic inheritance, multifactorial inheritance. Now, the genes associated with CDH are being reported in multiple literature, the important being transcription factors, retinoid signaling pathway factors, the FOC2, like that. And the genes that are known to affect both the lung and diaphragm development include the FOC2, that is the friend of GATA2 gene, and GATA binding protein 4, that is GATA4 gene. So these gene defects are reported in multiple literature when there is CDH present in the fetus. Now, as I have already discussed about the trisomies, there is tetrasomy 12p named as Pallister-Killian syndrome is a known syndrome associated with CDH. There can be microdeletion, duplication, Mendelian disorders, and another most common syndrome, that is a French syndrome, where the gene is unknown, still unknown. Here are some monogenic syndromes. Again, the French syndrome, the inheritance pattern is thought to be autosomal recessive from the reported literature, and we can't definitely say about the loci of the affected gene. So no disease causing gene is still be identified. However, there is a few reports of 15q and 8p microdeletions associated with French syndromic phenotypes. Now we'll discuss two cases and case reports here. Pallister-Killian syndrome is tetrasomy 12p. 40% is associated with CDH. There can be fetal macrosomia, cerebral ventriculomegaly, increased nuchal translucency, rhizomelic limbs, polyhydramnios, and abnormal facial profile. So I would like to discuss this article. Here they have highlighted on the prenatal aspects of the PKs, that is Pallister-Killian syndrome. So they depicted and discussed about this flat facial profile. Then there is prenasal edema in the ultrasound. This fat facial profile can be identified in the 3D ultrasound also. And in those affected fetus, after autopsy, left-sided CDH are being identified. There is post-axial polydactyly in all 4 limbs. And when the karyotyping was done, the duplication in 12p 13.33, that is the tetrasomy 12p, is identified. And so they concluded then whenever these markers are present in ultrasound, we should think for tetrasomy p and offered a detailed genetic testing, and they advise that the amniotic fluid is the base sample for such testing. Now coming to French syndrome, it is most common syndrome associated. Diaphragmatic hernia is present in 90% of cases. There is again characteristic facial appearance, digital distal hypoplasia, pulmonary hypoplasia, and the pathological variant is the PIGN gene. Now I would like to discuss another case published by Dr. Nirja Gupta madam. So it is a 4th case identified with such association of nasopharyngeal teratoma along with congenital diaphragmatic hernia and Dandy-Walker malformation. So this primi gravida presented at 20 weeks in the genetic clinic with ultrasound features suggestive of congenital diaphragmatic hernia and Dandy-Walker syndrome. Subsequently, MRI was done and confirmed this finding, Along with this, a mass identified arising from the hard palate. So the parents was counseled, and the pregnancy was terminated. The fetus had this scaphoid abdomen suggestive of congenital diaphragmatic hernia. There was characterized as facial profiles like hypertelorism, and on a closer view, a polypoidal mass was identified in the nasopharyngeal area, and after histopathological confirmation, it was identified to be a teratoma. All genetic testing was done subsequently. The fetal karyotype was normal. Chromosomal microarray didn't show any copy number variation. Whole exome analysis was done, and a few important gene variation was identified. Although no PIGN gene, that is the gene responsible for French syndrome, was present, a novel variation of the HIRA gene was identified. So to conclude my talk, although congenital diaphragmatic hernia is considered as a developmental defect, it is associated with various syndromes and chromosomal anomalies and should always be considered. In syndromic fetus, autopsy must be carried out and a detailed genetic testing should be performed after taking the parents' consent. In live-born fetus with no prior genetic screening, karyotyping at least should be offered and other features above mentioned syndrome should be looked for. Thank you, and I'll invite Nirja ma'am to give her expert comments on this. Ma'am, please unmute. Ma'am, your voice is breaking, ma'am.
Hello, is it better?
Yes,
Yes,
now it's
ma'am.
fine.
Can you hear me?
Yes, ma'am.
Okay. So thank you, Suchananda, for a nice presentation. So the idea of presenting these two cases was that we may or may not detect a causal etiology for congenital diaphragmatic hernia, even if it appears to be syndromic in nature. Like in first case, it was clearly syndromic, and genetic yield was possible, genetic diagnosis was possible. But in the second case, we were actually not sure about a specific diagnosis. So it is very important to look for the additional malformations on ultrasound and confirm them by doing the autopsy. I think this teratoma was not identified by on the nasal aspect. It was not identified on ultrasound, and only the autopsy was able to identify it. So it is important to do the postnatal evaluation of the baby, even if the baby is live or the pregnancy is terminated. And because it gives insights into the various genetic aspects of a particular disorder. So in this case, a variant in HIRA gene was identified, which is in the 22q deletion region, but we are not yet sure about this specific association. So I would, so if there are any other queries, I'm happy to answer that.
I think the queries will be there in the chat box. So if you could join us during the Q&A session,
Okay.
we would be really grateful. Thank you. Thank you so much for your inputs. And thank you, Suchanna. We move to the next presentation, and I invite Dr. Shravani Reddy to share on the classical CDH ultrasound science. Dr. Shravani, please share your screen.
Is it visible now?
Yes.
It's visible. Make it full screen.
Good evening, everyone. Thank you, SFM team, for giving me this opportunity. I'm going to present a case on left-sided congenital diaphragmatic hernia and mainly focus on how to diagnose on ultrasound. And my moderator is Dr. Sumitra Bachani. As already described by the Dr. Suchandana, the left side hernia are the most common, which constitute about
75%, and they have a better prognosis. And these CDH are they are the evolving lesions. Mostly they are diagnosed from 18 to 22 weeks period of gestation. But because of good ultrasound equipment, now we are able to suspect CDH even from the 13 weeks period of gestation. Coming to my case, 29-year-old primigravida conceived after IUI conception. She came for NT scan. NT was 1.3 mm and nasal bone was seen. This was the axial section of the fetal upper abdomen. Usually at this level, the umbilical vein is seen. At this level, usually the stomach bubble should be seen. But here the stomach bubble is not seen. And these are the coronal as well as sagittal images which are not showing the stomach bubble. So the absent stomach bubble can be because of various causes. Usually it can be physiological emptying, which is transient. And it can also be because of lack of amniotic fluid, which is seen in case of oligohydramnios and anhydramnios. And impaired swallowing, which can occur because of esophageal atresia. If it is not associated with the tracheoesophageal fistula, especially the type 1 esophageal atresia. And if there is some obstructing oropharyngeal mass like cervical teratoma, that also results in impaired fetal swallowing. And certain CNS abnormalities and neuromuscular disorders can also result in impaired fetal swallowing. And in case of congenital diaphragmatic hernia, especially on the left side, if the herniation of the contents from abdomen into the thorax, especially the stomach, then the stomach is not seen in the abdomen. This was the article done by the Mario Ruscio et al. Mainly on behalf of European Reference Network on Rare Inherited and Congenital Anomalies, ERNICA. They have proposed a standardized prenatal ultrasound assessment for fetuses with congenital diaphragmatic hernia. Here, they have these are the various ultrasound images which have divided into various grades depending upon the stomach position in relation to the AV valves. This relationship helps in the prediction of CDH, which helps in survival, which helps in prognosis. So they have divided these into 4 grades. Grade 1, here the stomach bubble is not seen in the thorax. And in the grade 2, the stomach is seen anteriorly near to the chest wall. And in grade 3, the stomach is at the level of the AV valves, and it is also almost in the anterior half. And in the grade 4, the stomach is seen posterior to the AV valves. And this prognostic factor will be explained in future talks. And these are the various images showing the normal diaphragm in the first trimester scans. Here, these are the parasagittal plane of the fetal chest and the abdomen on the right side. Here we are seeing the hyperechogenic lungs. The lungs are hyperechogenic when compared to the liver, and they are separated by the dome-shaped diaphragm, which is hypoechoic. And this is the parasagittal plane of the fetal chest and the abdomen on the left side, where we can see the lungs are hyperechogenic, and here we are able to see the heart. And below the diaphragm, stomach is seen. And these are the coronal images of the fetal abdomen and the chest. This is the transabdominal one, and these are the transvaginal. Here the lungs are seen hyperechogenic, and they are separated by the below by the diaphragm. And these are the arrow marks showing the diaphragm. And these are better delineated in case of transvaginal, where the lungs are seen very hyperechogenic and the diaphragm is hypoechoic. These are the images in the second trimester scan, as explained in the previous image. This is the parasagittal plane of the fetal chest and abdomen on the left side. This is on the right side, and this is in the transvaginal plane. So our patient was advised to come at 18 weeks for anomaly scan, and she lost to follow-up, and she came at 24 weeks. At 24 weeks also, this is the axial section of the fetal abdomen. Here we are seeing the umbilical vein, but the stomach bubble is not seen. And this is the axial section of the fetal thorax, in which the heart is pushed to the right side with some anechoic fluid-filled space is noted on the left side. So the mediastinal shift is present. This is the normal four-chamber view of the heart. This is a axial section of the fetal thorax, that is like thoracic vertebra on the posterior and the ribs are the lateral. Usually the heart is located in the left anterior half of the chest and bordered by the lungs. And the normal cardiac axis is on the left side, which is 45 plus or minus 20 degrees. So whenever in the four-chamber view, if there is an abnormal axis, search for thoracic or cardiac abnormalities. And the mediastinal shift is like shifting of the central structures, especially the heart from one side to the other side. It can be because of thoracic mass, or it can be because of unilateral agenesis of the lungs, or it can be because of one side massive pleural effusion. So the thoracic mass can be because of either echogenic mass, or it can be cystic mass, or it can be complex involving both cystic and echogenic. The echogenic mass can be because of CDH whenever the contents are liver and bowel. Echogenic mass can also be type 3 CPAM, where the mass is like hyperechoic and it is solid. And bronchopulmonary sequestration can also present as an echogenic mass. These two can be differentiated by color Doppler, where CPAM has a direct blood supply from the pulmonary circulation, whereas a bronchopulmonary sequestration has a blood supply from the aorta and descending aorta. And echogenic mass can also be because of teratomas and also hematomas also. And the cystic mass in the CDH, it is caused when the stomach has a content. And type 1 and type 2 CPAM can also, microcystic and macrocystic can also present as a cystic mass in the thorax. And loculated pleural and pericardial effusion can also present as a cystic mass. In case of echogenic mass, the diaphragmatic line is very well enhanced and it is clearly seen. But in case of CDH, the diaphragmatic line is not seen. One of the differential diagnoses for CDH can be eventuation of diaphragm, in which the musculature of the diaphragm will be very weak, and that results in whenever there is an increase in abdominal pressure, there will be herniation of the contents of the abdomen into the thorax along with the diaphragm. It is usually diagnosed as CDH during the antenatal period, and it is actually diagnosed as an incidental finding during the intra-op period. So on the left side CDH, mostly the contents will be either it can be stomach or bowel, or it can be liver. The stomach is generally identified as a fluid-filled stomach. It is absent in the abdomen, and it is displaced into the lower thorax, and it can shift the heart from left side to right side. Here, as you can see in this image, in this video also, we are able to see the heart is pushed to the right side with the fluid-filled sac is seen on the left side. And the other contents can be the bowel. The bowel will appear as a heterogeneous lesion in the left chest, which results in right mediastinal shift. Usually, it is seen in case of third trimester when meconium gets accumulated in the bowel. That will be seen as a heterogeneous lesion. These are the various images showing the heterogeneous lesion. This is on the axial section of the fetal thorax, and this is the sagittal view showing the heterogeneous lesion. And sometimes when we can observe, we can see the peristaltic movements of the bowel in the fetal thorax also. And the liver can be identified as a homogeneous lesion, hypoechoic mass in the chest at the level of the heart, and it is continuous with the intra-abdominal liver. Usually the lungs will have a hyperechogenic when compared to the liver, and sometimes it will become difficult to differentiate between the lungs and the liver. So when we apply a colored Doppler, these are the images. These are axial section of the fetal abdomen. and here the liver is pushing the heart to the right side. So this can be, it is very difficult to differentiate whether it is a lung mass or the liver mass. So this can be applied when we apply a color Doppler. The hepatic vessels are seen in the thorax, or sometimes the gallbladder may also be seen. And here in this fetus, we are able to see the fork hand also here.
Shavni, go ahead. We are running short of time.
This was same. Ednica has proposed that standardized prenatal ultrasound assessment for CDH. In that, they have mentioned about the liver also. In the sagittal section, the liver is herniated from the abdomen to the thorax, and here we are seeing the hepatic vessels into the thorax. And usually on the gallbladder, which is anechoic structure, usually it should be seen on the right side. But whenever the liver is herniating into the thorax, it is the gallbladder is seen on the left side. And the course of the umbilical vein, generally it will be left side. But in case of when the liver is herniated into the thorax, it is seen on the left side. So whenever there is a difficulty in differentiating between the liver and the lung, we can use the fetal MRI. And normally, in 60% of the cases, the CDH is isolated, and 40% of the cases, it is associated with other anomalies. Usually, the structural anomalies, which is the CVS, is the commonest. In that, VSDs and ASDs are the common ones. This is one of the landmark studies done by the Professor Nicolaides, which has shown the predictors of the CDH which will be discussed in the future talks. And this baby had stillbirth at 28 weeks, and these are the images post delivery. The autopsy was done. It is showing the right side liver is herniated into the left side, and this we also found the fork hand of the fetus. These are actually the images in 2002, so these are like pre-microarray time, so the genetic evaluation could not be done during that time. And the ultrasound, so the final the ultrasound diagnosis of the left CDH is diagnosed by, on the four-chamber view, the stomach in the left hemothorax and the heart and mediastinum are displaced contralaterally, presence of bowel with peristalsis, and rarely spleen or left lobe of the liver is seen. And on the longitudinal view, there will be absence of hypoechoic contour of the diaphragm. So in my case, the left side CDH was confirmed with stomach, bowel, and liver as contents. There is no polyhydramnios, no other gross congenital anomalies.
Okay.
Thank you,
Thank
ma'am.
you. Yeah, thank you, Shavni, for a lucid presentation. And so we end this talk here. And the absence of stomach bubble as well as the mediastinal shift should be taken as red flags towards further investigating for CDH. And it is, of course, as the ultrasound pointers towards bowel, as Shavni has pointed out, is the very echogenic, inner rim surrounded by a hypoechoic outer rim, which is the musculature, and of course the peristalsis. And the presence of effusion, I think we can mention, Shavni, that there can be effusion because there can be irritation of the bowel, as well as there can be compression of the hepatic veins. So, however, the effusion here is not really taken as a prognostic marker. And in 5 to 29% cases, especially in the right CDH, effusion can be present. And fetal echo becomes very important because the cardiac anomalies are the commonest. However, certain features like, you may find the underfilled left ventricle because of the pressure of the mediastinal contents, and there may be hypoplasia, there may be pseudodextrocardia, and the size of the ventricle as well as the size of the pulmonary artery or the aorta, the great vessels, is not really, to be taken as a prognostic marker to predict the postnatal outcomes. So further on, of course, we will be discussing the prognostic markers. Dr. Vandana Chadda and Dr. Krishna will be, and the various LHR, the observed and expected LHR, then the lung to thorax ratio, quantitative lung index. Many of them have not yet been, quantified. So we thank you and we move on to our next talk then. Thank you, Shravani.
Thank
Can
you, ma'am.
stop screen share. So for our next talk, I invite Dr. Anna Fatima, and she will be presenting the uncommon CDH, and she will be the expert for this will be Dr. Vandana Chadda. Go ahead, Anna. Make it full screen, please.
A very good evening to everyone. I'd like to thank SFM for the opportunity. I will be touching upon the uncommon hernias. I've been guided by Dr. Vandana. We'll brace through the embryology of uncommon hernia, tabulation of right-sided diaphragmatic hernia case series, also touch upon an uncommon case of paraesophageal hernia, and will wind up with the outcome of right-sided hernia series with antenatal interventions. To revise the embryology with the perspective of CDH, the right posterolateral is less common than the left, accounts for about 15%, happens because of unfused pleuroperitoneal canal. 1 to 2% are anterior morgagni, happens because of unfused crural and sternal portion of the diaphragm. 3 of the very rare types, the congenital paraesophageal hernia, could be because of persistence of right pneumoenteric recess. Eventration, which is incomplete muscularization or innervation of the diaphragm. Central or septum transversum type represents the defect in the central tendon and pericardium, and the most extreme form, the absence of the hemidiaphragm or the diaphragmatic agenesis. On ultrasound, the lung appears more echogenic than the liver, and the latter has portohepatic venous branches, which are seen above the diaphragm in CDH by Doppler. Bowel has peristaltic movements, lumen, and muscularis and serosa layers. Right-sided CDH has extreme leftward shift of heart and similar looking liver along with lung on the right side. Stomach is pulled upwards but not completely seen inside the thoracic cavity. Whereas in the left CDH, some stomach is seen behind the left heart in four-chamber view, a mediastinal shift towards the right, and sometimes bowel peristalsis can also be seen in the thoracic cavity. We have a series of 5 cases of right-sided CDH, each having specific findings associated. 2 amongst them presented in second trimester and rest all came in third trimester. 2 of them had an elective abortion, 2 had neonatal demise, and 1 lost to follow-up. First was the case of a routine primigravida with no risk factors. Her primary level 2 scan, done at 18 weeks, gave a suspicion of leftward shift of heart. We recalled her at 20 weeks and we were able to see more evident push of heart towards the left. This is an axial four-chamber view of heart showing a leftward push of heart towards the thoracic cavity. A hypoechoic structure compared to lung, possibly liver, can be seen in the right thoracic cavity. Correlating this finding with the autopsy, we can see liver positioned in the right thoracic cavity, pushing the heart leftwards. Causes of extreme levocardia can be heart defects such as tetralogy of Fallot, truncus arteriosus, coarctation of aorta, and pulmonary stenosis, right-sided pericardial or pleural effusion, cardiomyopathy with complete absence of pericardium, and of course, the right-sided CDH. Second case was of a primigravida at third trimester, came for a second opinion with increased Leica and with a query of asymmetrical FGR having abdominal circumference less than the other biometric parameters. She had an early neonatal demise and the baby had a scaphoid abdomen bilateral foot drop, and muscle wasting, which could be seen on ultrasound as well. This emphasized on the fact that biometry alone in such cases is not enough to monitor FGR, and Doppler has its role. Next is the case of a primigravida in third trimester with a normal level 2 scan from a peripheral center. We saw a slight change in heart position at 27 weeks with right lobe of liver in the thoracic cavity. Which we could see it here. And we could see a break in the diaphragm. Also, there was a non-visualization of the right lung, bowel loop in the right hemithorax, and polyhydramnia. Microarray test for her fetus was normal, and she continued with her pregnancy, giving birth to a neonate at 36 weeks by an emergency LSCS in view of fetal distress. Unfortunately, baby could not be revived due to severe pulmonary hypoplasia. This video here shows how stomach is pulled across the midline towards the diaphragm as the bowel is pulled upwards. The observed to expected lung-head ratio was more than 45%. So we can say that if liver herniation is there in CDH, despite good observed to expected lung-head ratio, neonatal outcome is not good. A 30-year-old second gravida in her second trimester had a scan showing unilateral microphthalmia, atypically positioned stomach, which was pulled across the midline towards the diaphragm, and a very subtle change in heart axis. She had a second trimester MTP after taking a second opinion. Last was the very old case of right-sided CDH diagnosed in third trimester who lost to follow-up. This is a very rare case of recurrent bilateral CDH where we could see bowel loops in the thoracic cavity and stomach bubble above the diaphragm. This had a very early presentation and was a large hernia. This lady presented with her level 2 scan with a suspicion of CDH, and her microarray test was normal. On repeat scan, there was a very subtle axis deviation, no mediastinal shift, no bowel or liver shift. Stomach bubble was seen a little atypical in location, occasionally demonstrated behind the heart, medially in the lower midline. None of the classical signs of CDH were seen. She delivered at 36 weeks, 6 days period of gestation by an emergency LSCS in view of meconium stained liquor and fetal distress. Chest X-ray of the neonate showed a normal bilateral lung parenchyma and gas bubble in the retrocardiac region, and on CT, left-sided hiatal herniation with volvulus was suspected. Intraoperatively, no CDH was seen, but the antrum of the stomach was seen above the left diaphragm and eventration was suspected. She underwent placation of diaphragm and division of Ladd's band. But later on, the baby had continuous gastroesophageal reflux in the form of vomiting, which was not controlled conservatively, and the barium study showed paraesophageal hernia, for which Nissen's fundoplication was done. A very similar case was reported in the Journal of Pediatric Surgery, where there was a case of prenatally diagnosed congenital paraesophageal hernia with similar postnatal course. But in Indian literature, we cannot find a similar case in the best of our knowledge. Let's have a look at the trials on the right-sided CDH. A European multi-center study on prenatally diagnosed cases of isolated right CDH were prognosticated on the basis of observed to expected lung-head ratio and were counseled to choose between expectant antenatal management and antenatal interventions in the form of Fetal. Out of 265 cases of CDH, 86 were managed expectantly and 128 underwent Fetal. Survival rate of observed to expected lung-head ratio less than 45% was poor, of about 15% without any treatment, compared to 61% when this ratio was more than 45. But fetuses treated by Fetal despite poor prognostication marker survived better than those with lung-head ratio more than 45% but managed expectantly. The novel finding in this study was that in the right-sided CDH, survival rate can be predicted from prenatal lung size, and in cases of lung-head ratio less than 45%, it is improved by Fetal. Thank you.
Thank you, Dr. Anna. That was a very lucid presentation, and you shared very interesting cases, and they were all, I think, Dr. Vandana's cases. Would Dr. Vandana like to add something?
I think we'll be talking shortly on the prognostication for diaphragmatic hernia, and we'll take up some of the practice points there. But I really congratulate Anna for really putting across all the videos, etc., considering she's just starting out as a sonologist, I guess. And the 5 cases of right-sided diaphragmatic hernia were from a total series of 41 total cases of diaphragmatic hernia that we've seen over the past 16, 18 years or so. So most uniformly, all of them had a poor outcome. Either associations were more common than the left-sided, and even the neonatal outcomes were, despite the best efforts, the one odd case I remember where a lot of effort went into trying to resuscitate the baby, but the outcome was bad. So I think we can move on to the next talk, Dr. Sumitra, and we'll cover points there.
Sure. So next talk is yours only, Dr. Vandana. So I invite you to speak on the prognostic markers in ultrasound in a case of CDH, and the expert for the session will be Dr. Krishna Gopal. So invite to you and Dr. Krishna Gopal.
Thank you, ma'am.
Make it full screen.
First of all, I would like to thank the Society of Fetal Medicine for giving me this opportunity, and I'm really honored by that. And we'll move on to the topic of interest that we have today, that is evaluation of the prognostic factors in congenital diaphragmatic hernia. And I would like to acknowledge my colleague, Dr. Nikhil Kapoor, for giving some of the good videos here. And also I'm going to be co-sharing this platform with Dr. Gopal Krishnan, who will be taking over towards the end of the session. So in evaluation of prognostic factors, the checkpoints or the bullet points are the type of defect, the site or the size of defect, what are the associations there. And we have various imaging modalities like ultrasound and MRI, where we can look at lung dimensions and get an idea of how the baby is faring. So the site of hernia, the septum transversum defects, it goes without saying that these kind of large hernias where you have the entire central tendon missing would have worse prognosis, and such hernias would be associated with incarceration of the intestines as well as herniation of liver in the pericardial sac. Similarly, a congenital absence of the diaphragm would be associated with an extremely poor prognosis simply by the nature of the hernia. If you're looking at evaluation of the prognostic factors depending upon the site of defect, right versus left. Traditionally, we've been taught that the right side fares worse than the left side, but recent literature suggests otherwise. So you have this French national cohort study, which is published in 2020, and it clearly shows that there's no difference between the right and the left-sided hernias if you balance for the observed to expected lung head ratios and for the thoracic herniation of liver into the thoracic cavity. There was not much of difference in the outcomes of the two sides. Similarly, this another study which was published recently in 2020 has also supported that concept, that there's no significant difference in mortality, ECMO use, or pulmonary complications between the right and the left-sided hernias. Now, looking at some other prognostic markers, the earlier the diagnosis, the worse the prognosis, simply because it may be a larger lesion. If you have associated aneuploidies or microarray findings, it worsens. If you've associated anomalies, if you've delineated a syndrome, if there's esophageal compression and polyhydramnios, or if there is decreased venous return or venous compression leading to high drops, all of that can worsen the prognosis. Incidentally, the presence of a peritoneal sac gives you a better outlook here, but prenatal settings, we don't really see that. And this is a systematic review of pediatric series where ECMO utilization and patch repair were less if the baby had a hernial sac at the time of birth in a diaphragmatic hernia. Isolated cases would have better prognosis. So 30 to 70% of cases are isolated. And even if there is pulmonary hypoplasia, intestinal malrotation, and a cardiac dextroposition, that's just the CDH sequence. And that does not negate the designation isolated CDH. And you have to understand that just because of compression, you may have a small ventricle, but because there's a high association with hypoplastic left heart syndromes and congenital diaphragmatic hernias, you should be clearly differentiating between these two lesions, because studies and literature suggest that even if there is a low flow through the left heart in mid and late gestation, once the baby is born, these high dimensions would normalize and this heart could have adequate biventricular circulation. So don't get disheartened if you don't see good flows in the second trimester, because these babies may just do well, and do your Z-scores carefully to look at the hypoplastic left heart. The non-isolated syndromic CDHs like the ones trisomy 18, 13, and 21, or you have some of the tetrasomy 12p that we've discussed, some partial trisomies, you have copy number variations which have been published in literature associated with CDH. All of them will carry worse prognosis. Fringe syndrome we have discussed extensively in a previous lecture, would worsen the outcome. We have Pallister-Killian mosaic syndrome, which has been reported extensively with CDH in literature. And we also have other syndromes like this case report of a Donnai-Barrow syndrome, where prognostication would differ from an isolated CDH. So this is just enlisting the associated syndromes, and we've been through that in a previous lecture. This is another case that we've shared in this meeting before by one of the FNBs, and this is a hernia, and very old case, so maybe about 15 years back, and that's the forehand and the left-sided CDH associated with the forehand. This is before the microarray or the exome era, and there was no particular diagnosis made for this fetus because the chromosomes were normal. Similarly, this is a right-sided diaphragmatic hernia with a unilateral microphthalmia. And you can see here how the liver is pulled up and the gallbladder is atypical in position. The heart is shifted. And of course, the association makes this lesion a poor prognosis. This is a case where the previous baby had also got congenital diaphragmatic hernia. And you can clearly see here that there is bowel in both the right and the left thoracic areas. The stomach is pulled up, and the exome sequence exome here for the fetus showed a variation in the ZFP-M2 gene, but that was not clearly of a significance as per the lab. Happily, this couple has had a normal baby after this particular two mishaps. So how do you decide the recurrence risk? The recurrence risk would be 1 to 2% after one affected child and less than 5% when a conglomeration of anomalies was present, generally following our principles of multifactorial inheritance counseling. If you have a lot of fluid like this baby here, you have a compressed placenta because of the fluid, and clearly there is a fluid here, maybe because of esophageal compression, and there is some degree of hydrops which can be associated with some fetuses. Now in this fetus, you can see the liver pushing up there. There's the scaphoid abdomen there. And this baby also had, this is the lower limb, and you can see some sort of muscle wasting. And the foot here seems malaligned. Abnormal venous pattern of the liver here. So this baby also, as expected, would have a poor prognosis. And this baby had a neonatal demise. So the predictors of outcome, again, depend a lot on the lung. It's lung. So you can have the lung area, you can measure the lung head ratio, you can measure the observed to expected lung head ratio. You can look at the liver to see whether the liver is up or down, and the liver to thoracic ratios. We have ways of grading stomach now, and to decide where the stomach is to prognosticate. And we can look at these 3D defects also in the MRI. So this kind of tracing or longitudinal large diameter method, this is the tracing method here, which is the preferred method of all these three methods here to trace the lung area. So we can look at the lung area on ultrasound, and this is the preferred method to trace the lung area. It's the most reproducible method, the tracing method, and it gives us the least error when you compare with the other methods, which is the longest diameter method and the anterior posterior diameter method. And we'll go over it elaborately by Dr. Krishna. So the lung head ratio, obviously, as it gets higher and higher, the prognosis gets better. And if your lung head ratio is less than 1, then the prognosis is really poor. So observed to expected lung head ratios is what we use now. The lung head ratio is not so much indicative of morbidity, mortality, and now is more indicative of morbidity as the survival rates have gotten better and better than the past. So we'll also talk about how to measure the observed to expected lung head ratio by my next speaker. But as it goes without saying, the higher the OE-LHR, the better the survival rate. So anything above 45% may be associated with survival more than 75%, and anything less than 25% has a very poor prognosis. In a right-sided hernia, even anything less than 45% would have a poor prognosis. Liver herniation survival rates improve significantly if there's no liver, as high as 75% if there's no liver. And ultrasound is definitely not comparable to MRI. MRI will give us a better quantification of the liver inside the thoracic cavity. And the observed to expected LHR and the liver position combined give us percentages in terms of survival. And this is a very nice table looking at the survival rates combining the two. So I would hand over the forum now to my esteemed colleague, Dr. Krishna. And he would be taking us through these next points. And Dr. Krishna, I would like you to elaborate on how do you grade the stomach and how do you use that to decide on the prognosis? How do you calculate the lung head ratio practically, sir? And how do you measure lung volume in ultrasound or MRI, and how useful is that? And any recent updates that you've had in the MRI literature for diaphragmatic hernia, we would love to hear from you, sir. Over to Dr. Krishna.
Thanks, Dr. Vandana. I must congratulate Dr. Sumitra and Dr. Vandana for putting such a nice academic meeting today. And I'm just sharing my slides. Give me a
I'm
second.
stopping here. Yeah.
Yeah. So thanks so much. I will tell you few of the things that Dr. Vandana has already told you, and few of the things that she has not. For next 2 to 3 minutes, I will go briefly through it and will add whatever it was not there. So where I have been left is that we have few of the predictors of the outcome. That is a lung size, that is a lung head ratio, observed and expected lung head ratio, and observed and expected total fetal lung volume, that is mostly calculated by our MRI. We also have our liver position, which is liver up and down, liver to thoracic ratio, stomach position, and 3D defect size by calculation of MRI. So how to measure lung head ratio? It should be measured in the axial plane at the level of 4-chamber view, with maximum of 2 ribs should be visible. And many times I have seen people measuring on the same side, but it must be measured on the contralateral side, because we have to see that whatever the lung has been residual, whether the lung is there, because we have to see for the prognosis of the fetus. Lung to be measured ideally close to the uh, to the transducer. So here we are saying that there is a left-sided hernia. Stomach is herniating into the thorax. So we are measuring here opposite lung. So
Friend, your screen is not visible.
Okay, let me
Can you share screen again?
Yeah, sure. Is it visible now?
Yes, sir.
Yes.
So, from which slide that was not visible?
From the beginning.
So this one was there visible, first one.
I think you begin from the start.
Okay. So we have our predictors of outcome, that is lung size, that is lung head ratio, observed and expected lung head ratio, and observed and expected total fetal lung volume, that is measured by MRI. Then we have our liver position, that is liver up and down, liver to thoracic ratio, stomach position, and 3D defect size. So how to measure the lung head ratio? So it should be measured in the axial plane at the level of 4-chamber view, with maximum of 2 ribs should be visible. The lung contralateral to the CDH is measured. Like in this case, where there is a gastric herniation, stomach herniation, so we are measuring the contralateral, the right lung. Lung to be measured ideally close to the transducer, and it is to be measured by 2 methods: the longest axis method and the tracing method. But if we calculate, if we see the papers published where we need to see that how to measure it, then the longest diameter method overestimate the right and lung area by about 45% compared to the tracing method. So tracing method is much better than that of the longest diameter method. Now, because lung area grows more than head circumference. They doesn't grow with gestational age exponentially. So we have to correct it for that gestational age. So observed and expected lung head ratio actually correct it for that given gestational age, but we need not to calculate it on the paper by the pen. We have, for our convenience, web-based calculator, and one of the most popular calculator is of the Perinatology.com. Here you can use both the method, that is the longest diameter method, where you measure the length 1 and length 2. You can also measure the area by the tracing method. When you enter the fetal head circumference and the gestational age, then it will calculate the expected and observed lung head ratio plus the a percentage by the various authors. So basically, lung head ratio, when it is less than 1, prognosis is poor. When it is 1 to 1.4, extracorporeal membranous oxygen is often needed. And when it is more than 1.4, then prognosis is good. In observed to expected lung head ratio, it is when it is more than 45%, there is near 100% of survival. When it is less than 25%, there is a very good prognosis. And in cases of right CDH, observed to expected lung head ratio of less than 45%, there is a good survival. So what is liver in thorax? Actually, when the liver is up and down. So liver up means that liver is in the thorax, and liver down means that it is in the abdomen. So what is the portion that is in the thorax is called liver up, and what the portion that is in the abdomen is called liver down. So in the left CDH, it is an independent predictor next to the lung size, but it is not very easy because echogenicity is similar to the lung. So we have to be very, very careful when we see this. We can diagnose it by the direct sign where we are seeing liver in the thorax and we can make out, but many times it is difficult. So we have to see the structures associated with the liver, like the gallbladder, ductus venosus, and portal vein in the thorax. And in these cases, the color Doppler is very, very helpful. Many times we put the color and we see the vessels going to the thorax. Stomach position is an indirect method to estimate severity of the disease, and it correlates with the proportion of intrathoracic liver by magnetic resonance imaging, MRI. So there is a grading also. So grade 1 is when it is seen in the abdomen, that is the normal position. Grade 2, when it is anteriorly near the apex of the heart. Grade 3, when it is not in contact with the anterior chest wall, but it is next to the atrioventricular wall, but it is still anterior. Grade 4 is when most of the stomach located posterior to the AV wall, next to the left atrium within the right chest. So if we see here that in grade 1, there is no stomach in the thorax. In grade 2, it is near to the apex. In grade 3, though it is anterior, but it is at the level of the atrioventricular wall. In grade 4, it is posterior and it is near to the left atrium. But only liver position is not important. We have to correlate it with the observed and expected lung head ratio. Because if we see in this trial, we are seeing that in even the extreme cases where survival is very poor, liver in the thorax that is seen by the lighter blue color and liver in the abdomen that is a darker blue color, it is both are not there. Even in the severe cases, when the survival increases, there is a liver in the thorax is a very small segment, and even in the mild cases we are seeing that there is a significant amount of liver in the thorax. So we have to always see both the observed and expected lung head ratio, as well as the position of the liver. So now the question comes that whether fetal the MRI stands. So this paper published in 2019 a SWOG journal that says that MRI based 3D reconstruction of the fetal diaphragm in CDH has been validated to visualize, locate, classify and quantify the defect. So that is why it is important in the planning of the postnatal surgery. So planning of the postnatal surgery may be optimized by our MRI based prediction of the necessity for patch placement and the ability to personalize pad design based on the 3D printable templates. So how it works. So if we see here that the section has been taken at the level of the xiphisternum here, and we see both the lung size as well as the defect size, and there is a dedicated software for that actually calculate it and print it in a 3D template where the this patch, reddish patch are the lung volume, and this patch, yellow patch, is the defect. So it is quite helpful the planning for the postnatal surgery. So what now we have on ultrasound our observed to expected lung head ratio. The MRI we have total fetal lung volume that is observed and expected. On ultrasound, we have our liver position, whereas in MRI, we have our liver to thoracic ratio. In stomach grading can be done by both, but 3D defect and the postnatal planning, for these two purposes, I think MRI is much better. So the take-home message is we should first exclude associated chromosomal and non-chromosomal syndrome, observe to expected lung ratio along with liver and stomach position, and the MRI particularly for the postnatal surgery. Thanks so much for your kind attention.
Thank you, Dr. Vanna and Dr. Krishna, for this very lucid presentation and the pointers towards the prognostic indicators. Can we have the 5-minute break for the trademark videos, please? Thank you very much. So moving on from the known to the new to the latest, we are all looking forward to the second half of the session where we're going to hear from a team from Amrita regarding the antenatal interventions. So I invite for this session Dr. Vivek Krishnan. He's the Clinical Associate Professor and Head Division of Fetal Medicine and Perinatology at the Amrita Center of Excellence in Fetal Care, AIIMS, Kochi. He's also a faculty for the Fetal Ultrasound Program. He has authored various books and long cases, and he's also a certified trainer. He has received training in fetal therapy at Berlin Fetal Care Academy. So we look forward to hearing from you regarding the antenatal interventions, and sir will also be sharing he'll be introducing his co-faculty and co-team members. Dr. Vivek Krishnan, sir, please.
Yes, thank you, madam. If I can share my screen first. Are you seeing the screen?
Yes.
Okay. So first of all, as always, thanks to SFM for this wonderful opportunity. I'm glad this was a conscious decision taken to discuss one particular topic, which has been controversial for quite a while, as Ashok sir put it right at the beginning. And I must start off saying that I was quite rather extremely fortunate to be starting off my career at a center like Amrita, where when I joined, every other specialist that you would want to under one roof was available in place, and all I had to do when I joined was to bring them all together and amalgamate the services of all the subspecialists. And that is how the Center of Excellence in Fetal Care was born back in 2014. Ever since, it has been this unified workforce that has achieved, that has helped us achieve what we have, which probably we could never have done as individuals. So that is the power of teamwork that we fully and truly believe in, and which is what has been our driving force in all these years. And one of the classical examples that typifies this force of the teamwork is congenital diaphragmatic hernia, wherein we have shown over the years in our series of 470 cases that if you have a proper diagnosis in place and you have a planned peripartum care, the outcomes could be significantly much better than otherwise. And that's why when Dr. Sumitra asked me to speak on antenatal interventions in CDH, I requested her that she allows my team to take this forward rather than me speaking alone. He was quite kind enough to consent to that, and which is why I have with me my head of the Department of Pediatric Surgery, a doyen of pediatric surgery in Professor Mohan Abraham, and a very rare breed of neonatologist in Dr. Paraju Dandapudi, who works simultaneously both in Amrita as well as in King's College, the birthplace of fetal medicine. So they'll bring all their experience together. And Dr. Mohan will first take you through the evolution of the tracheal occlusion, the endoluminal tracheal occlusion procedure, how do you select cases, the techniques, and then I hope I didn't share the case that we did at our center as well. I'll then come in and step over and take you through very briefly about the total trial and the results that have just been published by Jan de Prest and co. And of course, Dr. Raju will take you through the medical intervention that is quite possible in diaphragmatic hernia patients, the different drugs that have been tried, and how each of them have fared in the respective trials. So I think we'll start our work first with Professor Mohan Abraham. He'll take you through the procedure of Fetal and how it is done, and where it can be done, and what are the pitfalls that can come in. Over to you, sir.
Okay, can you hear me?
Yes, sir. You have to share your screen. Yes.
Can I share my screen? Or you are sharing?
I've stopped sharing.
Okay. I don't know what's happening.
Yes, we can see your screen.
Okay, right. I'll do it.
I think it's down there on your taskbar. Okay.
Yeah, I know. Okay, got it. Can you see my screen now?
Yes, sir.
Okay.
Full screen, please.
Yeah, I'll go. Right. Now I'll just go through briefly a history of how this Fetal trial came into existence, and then its pros and cons, and then I will show you how we are doing it. Now, it's way back in 1990 that the fetal surgery for CDH was open fetal surgery. And then the baby was taken out of the womb, the diaphragm was corrected and then put back in. Now, there was a problem with that. Most of them died. And the reason was when you reduce this thing into the abdomen, there is occlusion of the blood flow through the umbilical vein. And that results in the death of the fetus. So in 1994, we realized that when there is an obstruction to the airway, like in a cow, there is enlargement or distension of the lung, and we get oversized lung. That led to the thought, then why don't we just occlude the trachea and we produce a growth of the lung? And this is tried in the fetal lamp. And later on, as an open fetal surgery where the baby's neck was taken out of the uterus, a dissection was done, and a surgical clip was put on the trachea. This did lead to improvement in the outcome, but these babies had very severe tracheal atresia, tracheal stenosis, which are very difficult to correct. So it is Harrison again were the first to introduce the concept of animal model by deflation of a previously inflated intrathoracic balloon. Now, before we go in, we prime the mother with tocolytic, vaginal progesterone night before the surgery. This is continued till delivery. And indomethacin 50 milligram rectal suppository 30 minutes before surgery, and then every 6 hours for 1 or 2 days. And again, nifedipine till surgery. Now, these are a few things that we need: a good ultrasound machine, and this armamentarium for the fetal. This is the fetal scope that we are seeing with the telescope there. And this is a sheath. It's a curved sheath, and the tip is blunt so that it doesn't harm the trachea. This is a balloon, and this contains about 0.6 ml of saline. And this is the stem of the balloon, which costs about 80,000 rupees. And the balloon itself costs another 20,000 rupees. So the total cost will come to around 1 lakh. Or rather with GST and everything about 1,20,000. It's called gall ball 2, is about 7 millimeter in diameter and about 20 millimeter in length. This is a graphic representation of how you put it in. You go at this angle, enter the trachea, go into the trachea, and just above the carina, you inflate the balloon. Now, I'll show you this video. And once the balloon is inflated, you advance the fetoscope. I'm going into the amniotic sac now. What you're seeing is the nose of the baby. Now that's the lip. You use the tongue as a guide. You can see the papilla of the lung as you go in. Now that's the papilla. And then as you go in, you come across the glottis. Now, sometimes you go into the esophagus. It doesn't matter. That's a glottis. You go behind the glottis. If you can get into the trachea at that point, is well and good. But sometimes we have to go into the esophagus. Here, as you know, you'll see you are going into the esophagus. And when what you do is when you come back, and when you're coming back, you tilt your scope, because the curved scope, you tilt it so that it comes into the glottic area. And see, you're coming into the glottic area, and then you slip it into the trachea. It's a little tricky there. You may have to try it, once or more. They have come out now. Now I'm going in again. Now this time I'm not going into the trachea because I have seen the anatomy. So that's a glottis. Just slip it in. Now you make sure it is a trachea because you see the carina. And once you see the carina, you are sure you are in the trachea. Here you advance the balloon just above the carina. Then what you do is you advance the fetoscope so that the balloon, once it is inflated, is larger than the scope. So the balloon will stay there, and just pull on the stem, it gets detached and come off. Actually, in this case, we could not do that. This balloon that I'm showing you is actually taken from the net. What happened is there was a little bend on our scope, so the balloon we were not able to push the balloon down. So that's what it is. And then so in 2007, they found that severe CDA, the fetal procedure, increased survival rate from 24.1 to 49.1%, but still is under 50%. So that is something which you have to tell the parents and prime the parents. We are not promising that you are going to have a 100% survival with the baby. Now, in 2008, they found the tracheal occlusion reduces the number of type 2 pneumocytes and suffocant, because type 2 pneumocytes is that which produces suffocant. So if that is suppressed, then the baby is born without suffocant. And this is also the rationale behind balloon retrieval by 33 to 34%. And this can be easily done by ultrasound. You just puncture the balloon under ultrasound guided, and once it's punctured, it stays there. It may come out of the trachea by natural means inside the womb, or the baby may cough it out with the first cry. Now, if that doesn't happen, you can still do a bronchoscope and retrieve the balloon. It's so small, usually it doesn't produce any tracheal obstruction. Now, another side effect of Fetal is a tracheomegaly. It produces some brassy cough. Apart from that, there is no clinical importance to it. And prenatal balloon removal is also associated with lower morbidity and a better survival rate. The most common and important complication of Fetal is the early rupture of membrane with vaginal leakage and amniotic fluid. And this, our baby also had a vaginal leak. This problem occurs within 1 week from Fetal in about 5% cases, and within 6 weeks in about 20% cases. And that is important again. You have to tell the parents that up to 6 weeks, they have to be careful about the leak. And I mean, you know, it's not a black and white thing. It's an gray area where you really have to take the parents into confidence. And if they are willing to accept the risk and, you know, and the benefit, then only we need to go in. Thank you.
Yes, so thank you, sir, for that walkthrough through the procedure. So we'll now discuss in brief about the total trial. Hope my screen is shared. Right, so the total trial is an acronym for tracheal occlusion to accelerate lung growth. You've heard from Professor Mohan Abraham as to the fact that Fetal is, although technically challenging, very much feasible in our setup. And we always knew that this procedure had the proof of principle, because we have seen, as he was mentioning, from our own experience, that when you see cases with a higher obstruction, you have significantly ballooned out lungs and a compressed heart in between, simply because the lungs are ballooned out. So essentially, what this tells you is that if there is a block higher up in the thorax, in the trachea, this leads to accumulation of fluid within the lungs, and that leads to the enhanced lung growth. So in other words, high airway obstruction, whether artificial or natural, can induce or stimulate lung growth. We also have data from animal studies that said that if you follow the plug-unplug sequence, which means you induce obstruction, and then maybe sometime later you reverse the obstruction, this helps the pneumocyte maturation that Mohan sir was just talking about. So obstruction stimulates lung growth, and the plug-unplug sequence stimulates lung maturation. So this is what the data was available with us. And then Professor Jan de Press came with this procedure of Fetal. He described the procedure in the paper published in 2004. And then came the second paper again from his group, which looked at the safety data, because that was very important if they were to go ahead with this procedure. This paper on 210 cases that they did came up with this conclusion that you have an acceptable safety profile for the mother. So there is at least no harm intended to the mother here. But there were, of course, significant risks of preterm labor there. So the question that was unanswered with all these studies, which were not randomized studies, was that given this risk of preterm labor, was it worth taking the risk? In other words, would it be better to just continue with expecting management and postnatal care? Do we have a very significant benefit as to promote this as the primary treatment modality, CDH? Now, this sort of a question can only be answered by a randomized trial, where you randomize into one arm that undergoes the treatment and the other arm that goes into expecting management. This is exactly what the total trial did, and that is what it was designed for. So basically, the total trial was two companion trials that ran parallelly for close to around 10 years, close to a decade. Basically, they looked at two groups. One was severe CDH, severe left-sided diaphragmatic hernia, and the other was moderate left-sided diaphragmatic hernia. They randomized these groups into receiving fetal endoscopic tracheal occlusion, the fetal procedure, and in the other group, which was supposed to receive only trachea care, and the postnatal care was standardized for both the groups, irrespective of whether the group underwent or the mother underwent fetal or not. The postnatal care was the same in either case. So this was the total trial in a nutshell. Now, what or how they classified these babies into severe and moderate is purely based on the observed by lung head ratio, which you've heard of quite a bit in the last few minutes. Now, based on the O by E LHR, the severity of diaphragmatic hernia has been grouped in the extreme when the LHR is less than 15. We're not bothered about that particular group, nor are we bothered about the mild group where the LHR is above 45. So if the LHR was between 15 and 25, that was severe. So that was the group that was included in the first trial. And if it was between 26 and 35, that is moderate, and these babies were included in the second trial. But there's another group of 36 to 45, where if the liver was involved, it also fell into the moderate category because it behaved similar in terms of survival to the moderate group anyways. So you have the severe group with 15 to 25, you had the moderate group with 26 to 35 and 36 to 45 with liver involvement groups. And these were the two groups that were considered for the total trial. Now, as I said, the two trials ran in parallel and they looked at similar outcomes. Of course, the primary outcome was survival, the discharge and survival at the end of 6 months. There were 14 centers with specific skill criteria for people that were involved in the antenatal management and 46 unit tertiary care centers that took over the postnatal care, meaning all of these babies that underwent the total trial or the procedure were not required to deliver at the site that the procedure was performed. They could, once the balloon was retrieved, go back to their center of choice and get delivered at their preferred hospital. Now, this was spread across 15 countries, and the trial followed what we call as a group sequential design. It means at every stage you had interim analysis. Now, this is basically to look for superiority of one method over the other. For example, if I find at the end of my first interim analysis that Fetal offers a very significant benefit over expectant management, my trial stops there, and then from there on, there's no randomization for every patient who comes to the clinic to offer Fetal. So that is what is meant by group sequential design. And in this particular trial, the severe group had to be terminated, or the trial had to be terminated after the third interim analysis, because they found that the Fetal procedure was far, far superior to expectant management, which is what we will come to in the next few slides. Now, the inclusion criteria, of course, they included only left-sided CDH, right-sided CDH was not considered. They also had to rule out any anomaly that is associated with chromosomal or structural. So they included singleton pregnancy with the mother being over 18 years of age. Exclusion criteria, of course, associated anomalies, maternal risk factors for surgery like severe obesity, multiple large fibroids, or when there was an ultrasound of perceived risk of preterm birth, either because the cervix was short or the mother had structural anomalies, or there was a procedure previous. Now, there were 95 fetuses with severe CDH that met the inclusion criteria after all the exclusions, of which 47 were randomized to the fetal group and 48 to the expectant group. They followed a 1:1 randomization, a block randomization was called. Of these 47 and 48, 40 each were available for interim analysis at the end of the third interim analysis. And what statistical technique was followed was what we call the intention to treat analysis. On the other hand, the moderate group, of course, required larger numbers to do a benefit. So there were 196 mothers who were randomized to either receiving fetal or expecting in an equal proportion. And in this particular arm, all of them were available for the final analysis. Again, the analysis was made by intention to treat technique. Now, the timing of balloon insertion and removal was different here, because in the severe group, the balloons were inserted between 27 and 30 weeks. Whereas in the moderate group, they delayed it so that they could minimize the risk of preterm delivery. When the lungs were slightly better, they thought, why risk this mother to preterm birth? We should rather try and push the intervention by a little later. So that even if the mother goes into preterm labor or pre-prom, the baby is still salvageable at around 31 weeks rather than 27 weeks. So that was the only difference. In both cases, the balloons were removed between 34 and 25 weeks. So in the severe group, the point is the balloons remained in situ for longer, for an average more than 2 weeks or 3 weeks than the moderate group. As I said before, once delivered, or once the balloons were retrieved, both the treatment arms followed the same standardized protocol. So the primary outcomes that were looked into were survival to discharge, and of course, as the secondary outcomes, we also looked at survival at 6 months and all the other complications of the procedure that could be seen. Now, severe CDH, this is perhaps the most important slide of the trial. You look at this particular slide, it's very, very clear that in the fetal group, which is shown in blue, versus the expectant group, which is shown in maroon, there was a significant benefit to survival advantage that was seen. 40% of these babies survived to discharge once fetal was done, compared to only 15% when the expectant management was followed. And the same pattern was reflected at 6 months follow-up as well. And this was a very, very significant finding. So this clearly, at the end of the third interim analysis, told us that if you go in and do fetal, you have a significant improvement in survival, which is why the trial had to be terminated at the end of the third interim analysis, because it was a very, very clear, statistically significant survival advantage. There was a superiority of fetal over expectant management, therefore the interim trial. The severe trial had to be stopped at the end of the third analysis. Whereas in contrast, in the moderate CDH group, there was, of course, a mild increase of slightly beneficial increment in survival, but this, however, was not statistically significant. 60 versus 50% to discharge, and as you can see from the p-value, this is not statistically significant, unlike what was seen in the severe CDH group. Now, the secondary outcomes, as I said, were mostly about complications and the neonatal outcomes here. This was a very busy slide, but the only take home from this particular slide would be that there was a higher risk of PCOM and preterm labor as expected when you do a fetal intervention. And 1 in 3 of these cases either had a PCOM or a preterm labor before 33 weeks. This, of course, as you know, would lead to labor and babies. In the moderate group, again, this was the same problem that they faced. There was a 1 in 5 chance of the mother going in either for a PCOM or a preterm labor before 33 weeks, again leading to labor and babies. Apart from that, the neonatal outcomes were fairly comparable. The only difference being that in the fetal group, the requirement of ECMO was much, much lesser at 5% compared to 29% in the expectant group. Otherwise, the numbers were pretty much comparable. We also looked at adverse events between the two groups, and in both the trials, nothing much to write home there about, except for the fact that there was a 5% number that had problems with balloon retrieval, and there were neonatal deaths because of this. So balloon retrieval problems could lead to iatrogenic death, which is one particular complication that we need to warn patients about before they decide to go in for a tracheal occlusion. So to conclude, the major take home from the total trial was that in severe CDH, we have a certain survival benefit, whereas in moderate CDH, the effects were much, much more modest than that and non-significant if you look at in terms of statistical significance. Fetal in both these situations is associated with a higher risk of membrane rupture and prematurity. And we also have to warn patients that though maternal risks were limited, there could be problems with balloon retrieval, especially if we're not retrieving them at an elective pace in the center where the balloon was inserted, which is why patients need to be staying very close to the center that has inserted the balloon for appropriate retrieval. So if there is a failure of balloon retrieval, this could lead to iatrogenic fetal mortality, which is definitely not what we intend to do when we set out for the procedure. So that is in a nutshell about the total trial. I would, of course, end with a disclaimer. This is just a very gist of the whole trial. Remember, the trial ran for 10 years, and I just concluded or concise the results in 10 slides and spoke to you for 10 minutes. So I've not done justice to the trial. I said, I'm always ready for a larger critical evaluation of the trial any day, given an opportunity. So thank you very much. And now we come to the last part of this talk. And I would request my neonatology colleague, Dr. Raju, to take us through medical interventions in CDH.
A very good evening to all of you, and thank you for giving me this opportunity. Like we said, we'll be discussing about the medical interventions. But if you go back to the main goal of any of the antenatal interventions, it is twofold. One is to increase the lung volume prior to birth. And the second thing is obviously the main second complication that we look at once the babies are born, to try and ameliorate or even minimize the pulmonary hypertension in the postnatal period, and thereby try and increase the survival this rather very unique population of neonates. I mean, there are limitations for everything, and as such, even for fetal surgical intervention in the case of a diaphragmatic hernia, despite the use of keyhole surgery, and this is from a fetal consortium, about 200 cases, obviously PPROM rates of about 47%, and preterm birth with a median gestation of birth at around 35.3 weeks gestation. And that's a slightly older trial that data that's from 2007, if I'm not wrong. And a more recent trial in 2017 by Jimenez also kind of goes in the same, comes along in the same thing. Probably the preterm labor and this thing is slightly lower, but they're still fairly high. But the main concern is the unplanned removal of the balloon. And I've had some unfortunate instances where the removal of balloon has been a bit difficult, to say the least. It is a technically challenging procedure, and hats off to all those people who do it. It's not the easiest thing to do, which means that these parents have to stay close by to that center. And if you think about the expenditure that is involved postnatally, this just adds on to the burden of the financial burden of treating this disease. And again, success of the fetal is also physiologically a little bit dependent on what the existing lung is, because there are some studies, animal studies, that seem to suggest that once the intraluminal pressure reaches beyond 6 millimeters of mercury, the amount of pulmonary fluid, which we are trying to actually trap in and thereby increase the lung volume, also starts, the production of the lung fluid also starts tailing off. So that's something that we need to kind of keep in mind, particularly when this thing, but it's really reassuring from the total trial that the severe category seems to be doing pretty well. When you think about the three main things that have been looked at, is one is the glucocorticoids, which is bread and butter for all of us, both from neonates as well as obstetricians. The next thing is retinoids, and the most promising one that's we are looking at now is the PDE5 inhibitors. If we think about the glucocorticoids, you'd find that Liggins and Howey are the first ones, and followed by Ballard and Ballard, who demonstrated that the timing of the fetal lung maturity actually coincides with a physiological increase of circulating corticosteroids. And that was the rationale in which they started looking at trials looking at using betamethasone. And that was around 34 weeks gestation. But funnily enough, I mean, surprisingly, in the interim analysis of 32 cases, they found that actually with 17 intervention and 15 placebo, that it didn't show much of a difference in mortality, ventilation time, or length of stay. And that's the reason why the study was stopped prematurely, because what they found was for them to show a demonstrable improvement, they needed 1,700 cases, which is a large thing, and which kind of reflects on the kind of the paucity and the rarity of this condition that we tend to see. And that's also the reason why we should actually look into trying to have a multi-centric trials, and we should all pan up, team up to try and face this situation. But having said that, corticosteroids, we use it anyway in the preterm labor, which is the current standard of care. So we don't see any harm in trying to use corticosteroids. And it's just that we don't realize that in diaphragmatic hernia, it is one modality, medical modality, that was actually looked into. If you look at the next step, that was retinoids. I mean, vitamin A is an amazing vitamin, because it's one of the essential micronutrients that is required for organogenesis and cellular differentiation. And it has retinoid signaling pathways have also been implicated in the development of lung, normal pulmonary development, as well as diaphragmatic development. But the catch is that retinol, which is the active component of vitamin A, it has limited amount of placental transfer. And that was demonstrated in a trial where they looked at, in a study where they looked at vitamin A retinol levels in the mothers of diaphragmatic babies. They found that the levels in the mothers were more or less normal or slightly higher, whereas the levels in the babies were actually lower, which kind of suggests that, just dumping vitamin A into the mother may not be as helpful from that aspect of things. What we know that is that at the cellular level, it's a retinoic acid that actually is useful for having the positive effect that we are looking at for the retinoid signaling pathways. But the problem is, though retinoic acid crosses the placenta, it has teratogenic potential, which is fairly high, which is a bit of a catch-22, if I can say that. So that's something that we are kind of stumped with. And then we come to the phosphodiesterase 5 inhibitors, and sildenafil being the main thing, for the simple reason that taldefil doesn't necessarily cross the placenta. But we have, unlike corticosteroids, which have only equivocal response, retinoids being toxic, sildenafil and phosphodiesterase inhibitors have fairly good safety profile at conventional doses are used in humans, And we find that we have used it extensively in human population, and we know for sure that it crosses the placental barrier. We've used it in pulmonary hypertension. We've used it in growth retardation, where we have intrauterine growth retardation. And it has been investigated specifically in the diaphragmatic hernia setting, in nitrofen-induced congenital diaphragmatic hernia in the rat model, in the rabbit and sheep models as well. And it has a promising chemical, biological, as well as structural pulmonary vascular changes. The main mechanism of action being twofold, where sildenafil actually increases the cyclic GMP by its phosphodiesterase 5 inhibitor tendency, and thereby increases vasodilatation and increasing blood flow, and helps with the pulmonary hypertensive component. That is the retracting the pulmonary component of the pulmonary hypertension, which is actually responsive to our measures. But there is a fixed component of pulmonary hypertension that you tend to see in the diaphragmatic hernia babies, which is primarily because of the pulmonary artery smooth muscles. And this sildenafil has also been shown to have an anti-proliferative effect on these smooth muscles, and may reduce the increase in the distal artery muscularization, which is a bit of a characteristic finding in the congenital diaphragmatic hernia. So, I mean, to summarize, if you look at it, I mean, there is a trial that's going on, I think, by John Press, where he's looking at antenatal use of sildenafil in trying to improve the outcomes in congenital diaphragmatic hernia. We ourselves have tried to do a trial, but we couldn't achieve an equipoise, with all the mothers insisting on trying to be in the intervention group, though it was supposed to be a double-blinded RCT. So we had to stop the trial for ethical reasons. We didn't want to go ahead with it. In summary, I think I would say antenatal fetal surgical intervention in diaphragmatic hernia scenario does not as yet have all the right answers. We still need to be very careful about picking the right patient at the right time and in the right center. We do have a need for a good quality evidence for medical interventions which show good physiological potential in animal models. And for that, we need a recruiting base, in the sense that we cannot have a single center experience, which is, I don't think, which is just not good enough. And we do need to consider whether medical therapy is potentially a precursor or an adjuvant for a surgical intervention, where the double kind of an approach might just give us the added benefit of having a better outcome. So that's what I think, and thank you for your patience.
Thank you very much, sir. Dr. Vivek, sir, do you have any more comments?
No, ma'am, done.
Okay, thank you so much for this absolutely great insight and a very extensive coverage by Dr. Vivek, sir, Dr. Mohan, and Dr. Peraju, sir. And you have touched upon the most recent, as well as you've taken us through the trial. And we hope you will stay with us to address any questions. I'm sure the questions are coming up in the chat box. Thank you. And we'll just move on to the last part of the session, which is on antenatal care and postnatal surgeries. So for this session, I have with me, I can share the screen. So for this session, I have with me Dr. Shilpa Sharma. She is the additional professor of pediatric surgery at AIIMS, New Delhi. She has contributed to books and many articles. She has delivered multiple guest lectures and presentations, and currently she's the Secretary Research Section IAPS. And she has a very keen interest in antenatal diagnosis and neonatal surgery. So I will just present a case as an obstetrician, fetal medicine person, and Dr. Shilpa will be sharing her experience at AIIMS regarding the postnatal surgeries and the follow-up of these infants. So, I'll just start off. My case is a 31-year-old Mrs. X. She was the second gravida, para 1 live 1, a spontaneous conception, a non-sanguineous couple. Anti-scan was done. She missed the anomaly scan, as is very much common with our patients who come to us in public hospitals. So she finally came with a scan at 25 weeks, which said it's CDH. And looking at the images, and then we did a scan. The stomach bubble, of course, was not seen here. The position, we found it in the thorax next to the heart, and then we also found the bowel alongside it. So a clear-cut diagnosis of CDH with an LHR of 1.65 and an OE LHR of 68.7. So a good prognosis, survival of around 85%. So if we look at this clinical practice guideline, whenever we get a case like this as an obstetrician, and I'm doing my scans also, I need to know the type of CDH, the site, the contents which are herniated, then the fetal growth, amniotic fluid quantity, associated anomalies, fetal echo, of course, because fetal anomaly, cardiac anomalies being the commonest, any other fluid collection, LHR, the OE LHR, which is now already being discussed, the prognostic factors, the liver position, and very important, the genetic counseling and the analysis. So we know all about this. We have been explained very well. And so fetal echo in this case was normal. And we've already discussed that an apparent change in the heart because of the compression, which is the hypoplasia, would of course improve after surgical correction of CDH. So that is not taken as a prognostic marker. So the genetic counseling was offered to the couple, and they accepted, and amniocentesis was done in which the array did not reveal any pathogenic copy number variations. The couple was willing for follow-up and serial scans and delivery at our hospital. So finally, we had a pregnancy with the live fetus at 25 weeks, and the LICA was adequate. It was an isolated left CDH with stomach and bowel as content. The fetal echo was normal. The LHR predicted a good prognosis. We followed her up, and during follow-up, we need to look at the fetal growth. There can be a fetal growth restriction. We need to look at the LICA, because if the swallowing gets affected, then we can land up with polyhydramnios, and that kind of distresses the mother. Then we have to think of maybe doing an amnio reduction, but with its associated problem of preterm labor. We have to look at the LHR, any other evolving anomalies, and of course the role of antenatal steroids has already been discussed, need to be given in case of any preterm delivery. Fusions can also be present, and as I was saying earlier, that they may be present for other different reasons. And mostly this should be actually, when you talk about hydrops, the presence of effusion should be considered, the pleural as well as the ascites actually should be considered as a single compartment, because there is a communication between the two. So mostly this kind of effusion, we will not use it for prognostication. However, severe hydrops would be, of course, of concern. So we kept on following her, and till 36 weeks, the LHR was good. So now we were wondering about the timing and the mode of delivery. So there are various studies, of course, and the largest CDH study group data from 2001 to 2015, they had taken almost 3,900 cases, and they reported a 64% survival, but poor outcomes at an early gestational age. Similarly, another one in the FPT recently in 2021, 296 women comparing the early term and the late term deliveries, and they found that there were improved survival rates and less ECMO requirement in the late term. So finally, late term is definitely better. And what about the mode? So the mode of delivery would, of course, depend on the obstetric indication. And however, if the fetus has undergone interventions and something like an antenatal intervention, then possibly you might think of offering cesarean delivery also, because then that is a timed delivery and you have your team in place for that too. And looking at this paper of differences in outcomes in prenatally diagnosed congenital hernias compared to the postnatal detection, of course, they found that in fact the postnatal ones did better. But that could of course be because maybe the postnatal ones did not have that kind of a severe disease. So the delivery room team would should definitely consist of a senior obstetrician, a senior neonatologist, pediatric surgeon, a pediatric cardiologist. A neonatologist is the main should be the team leader here. So in our case, fortunately, the lady had a preterm rupture of membranes, pre-labor, not preterm, pre-labor rupture of membranes at 37 weeks. Plus 5 days, and she went into spontaneous labor. She had a normal vaginal delivery, and it was a male baby with an APGAR of 4.7. The baby got intubated at birth. And postnatal evaluation also, there were no anomalies. And on day 2, a laparotomy with reduction of the herniated contents was done with repairing the defect. Post-op ventilation was there for a day, and then the baby was slowly weaned off. The post-op period was uneventful, and the baby was discharged and is currently doing well. So of course, we all know the challenges which are there at birth, and they have the medical management has been very nicely discussed by Perinatal sir. So considering now we have Dr. Shilpa, you're there with us and you're the expert. So this was of course a case which went off well, but what exactly would you discuss in antenatal counseling with the parents? Because we do send our couple to the pediatric surgeon who is going to take care of the baby after delivery. And what will be the optimal condition or the clinical condition conducive to doing the surgery? And what is your experience at AIMS? Like, do antenatal CDH do better, or a postnatally diagnosed CDH, the surgery, the outcomes? What is the success rate, the long-term follow-up? So may I invite Dr. Shilpa to share your screen and continue with this.
So thank you, Dr. Sumitra and Dr. Vanna, for organizing this meet. It's been wonderful 2 hours now. So I'll begin with your first question. How do you antenatally counsel these patients?
Ma'am, can you make it full screen?
Yeah, I've made it full screen. So for the antenatal counseling will depend upon the age of gestation. So if it is less than 20 weeks, it's the parents' wish. If they want to go ahead for termination, they can, and we do not discourage that. However, of late, we had a lady who had gone to the court at 26 weeks asking for termination, and she came to us, and then we got genetic testing and amniocentesis done for her. Everything was normal. We did give her the permission to go ahead because she had got all that done from court, but we counseled her so well that despite getting the court permission to go ahead with the termination, she's now following up with us, and she is expecting to carry on the delivery till term. So she's now 27 weeks. So it all matters, because even if we allow a termination at 27 weeks, it's not going to be safe for the mother. The baby may be born with prematurity, and it's not ethical to allow the baby to just leave on care and without surgery at that age. So everything matters, and the destiny is also a big thing. So there are some patients, like if you go to a gynecologist, she will tell you 50% will survive, 50% will not. If you go to the neonatologist, he will also have a 30 to 50% survival rate. But if you talk to a pediatric surgeon, they will tell you there's a good survival up to 70%, 80%, even 90% in some centers. So definitely the ones that are coming postnatal are very good. The ones that we are seeing through the antenatal period, they do have a poor prognosis because they have been picked up early and the lungs have poor maturity. So from that, I'll begin. everybody can plan the delivery well in time. Vaginal delivery is acceptable unless there is a gynecological cause to go ahead with the cesarean section. And we can encourage delivery to carry on till at least 39 weeks to prevent prematurity. Bag and mask ventilation is to be avoided. And a large nasogastric tube should be put just soon after the baby is born so that minimize the air entry into the stomach. And if possible, even the rectal syringing can be done to empty the bowel if the baby is passing meconium soon after birth. It is preferable to electively ventilate the baby. Even if it is not needed, we prefer to ventilate it, and then the decision to continue the ventilation can be taken in the ICU. So if the babies are coming postnatally after delivery, the clinical signs and symptoms to be seen in the casualty will be cyanosis, respiratory distress, scaphoid abdomen. So if a neonatologist sees all these conditions, think of a CDH. A barrel-shaped chest. On auscultation, if the babies may come even as late as 2 years, on auscultation, you will find bowel sounds in the chest. Associated anomaly should also be looked for. For the workup, you put in a chest tube, you put in an NG tube and then take an X-ray so that you can see the stomach bubble going up and into the chest. Ultrasonography to look for the kidney and ureters and bladder should be done in all cases, because with congenital anomalies, you may have a baby who does not have both the kidneys. So there's no point in going ahead for surgery for such a baby. Echocardiography has been talked about. Blood gas analysis, pre-ductal and post-ductal oxygen saturation should be monitored. I have reduced my slides. Whatever has been discussed, have removed that. So I've just kept few of them. So ventilation management is important. Pulmonary hypertension is a big issue which needs to be taken care of, and the role of ECMO, which is not there in many centers in India, but in abroad it's a norm to go for ECMO for these babies. The ventilation described is gentle ventilation. That means minimal ventilation. You don't need to keep a saturation of 100%, even 85, 90, 95 is also fine. Permissive hypercapnia is another way to monitor these babies. If the babies have pulmonary hypertension, fluid restriction is done and blood pressure has to be optimized. The drug treatment we've already heard about. So there are many new drug treatments for pulmonary hypertension. Oxygen index should be monitored because the mortality depends. If it's more than 40, then ECMO is definitely needed. And in NHS, they shift the baby to a center where ECMO is there if the oxygen index is high. The baby goes on ECMO, can be operated on ECMO, and then baby comes back after that. The contraindications for ECMO are a gestational age of less than 34, weight less than 2 kg, if the baby is having bleeding disorders or if there's intraventricular hemorrhage. When to operate? As a surgeon, we would like to operate as soon as possible, but we all know now that it's a physiological disease and pre-surgical stabilization is the most important thing to do. So the right time is when the baby is absolutely fit to take in for surgery and the clinical condition is optimized. This may be as soon as 2 days after birth or maybe even up to 7 days after birth. But if it carries on longer, we need to take a decision on when to go ahead. I'll take you through two cases in which you will realize the need. So the pre-surgical stabilization is described as pre-ductal saturation of 85% and above, lactate level below 3, and urine output of more than 1 to 2 ml per kg per hour. The repair can be performed while the baby is on ECMO. The goals of surgical repair are reduction of the contents, assessment of the lung hypoplasia, and how to plan the defect repair. If it is a small defect A and B, it can be repaired without any need of a patch. Only the type D defects would require a big patch, small patch. And even after reduction, after putting in a patch if needed. Very rarely you will need to put in a patch. In my 20 years experience, I've just needed to put in a patch once, that also a partial patch. We should look for evidence of any compartment syndrome in the abdomen because that can lead to a high level of mortality. So this is very important for the neonatologist to make sure what's happening in the abdomen after the repair of the CDH. So these are types of defects, and one should emphasize to note down. Previously in India, we were not noting down the types of defects or how much the defect is. We just put a CDH defect in the posterior part. But now we have to measure these defects as they appear here. A, B are okay, C and D are major defects. So if somebody is repairing a D defect with a patch, you can imagine the amount of tension that will be here. There can be recurrence also. And if the diaphragm is totally flattened out, this will lead to more chances of abdominal compartment syndrome. The surgical approach can be from the abdomen side or from the chest side, both of which can be done with minimal invasive procedures like laparoscopy or thoracoscopy. We prefer to do a thoracoscopic approach. A robotic approach has also now been there, but it's not easy to do that in small kids, especially newborns. The instruments are not so suitable. This is a summary of the medical management. So I'll just take you through two cases. There was this baby S, who 29-year-old mother, who had come to us at early gestation. So she came at 19 weeks gestation with a CDH diagnosed on the left side. What would you advise this child? Normally they would tell, go ahead for termination, but this mother really wanted this baby. The baby, she had a previous history of abortion, and she wanted motherhood in her life. She was a Christian, and we counseled her, and she said, I would like to go ahead, even though she had polyhydramnios. So this was her antenatal ultrasound, and the LHR ratio was 0.6. So she was a high risk case. So we saw this baby and advised her to carry on till term. After birth, she was in the ICU, in the neonatal ICU. She had delivered, baby was cynosed, Apgar score was low. The pH was 6.8, saturation was 68. So baby had gone into shock just 1 hour after birth and was shifted on high frequency ventilation very soon. So here you can see the left CDH. The baby was stabilized with nasogastric tube, glycerin syringing, and discussed with the parents regarding the future plans. We had contemplated surgical correction once the baby is stable. So you can see her pH was only 6.8, triple inotropes. On day 6, the baby improved for some time. The inotropes were off, but again, the situation became worse and the baby was maintained on HFOV. She was planned for CDH repair, but could not be done because of HFOV. This general anesthesia, the baby was not fit for general anesthesia, as in our center, the anesthetists did not let us operate on HFOV. So we didn't know what to do. We thought we'll go in for surgery, and then we spoke to the neonatologist, and we decided that we will go ahead for surgery on HFOV, and we shifted the ventilation to the OT. So we operated this baby while the neonatologists were taking care at the head end with no anesthetist nearby. Though we had waited for 1 week for the baby to be off. So on day 14 of life, we had taken the baby to the OT. So this was the chart in the initial parts of the life. And you can see oxygen saturation was more than 40, it was 46. So we operated the baby, expiratory laparotomy was done in 45 minutes. The baby remained stable during surgery. I had a video here, but because of shortage of time, I'm not showing it. So post-operative, the baby maintained well. And on the day 31 of life, there was a failed extubation. And as you can see here, there is some haziness on the right side. So suspected a right side CDH2. So CT scan was done and there was a right side CDH here. So again, the baby was taken up for surgery and a second surgery was done to repair the right CDH, this time on normal ventilation with the anesthetist there. Post-operative course was quite stormy, but well maintained. The baby had needed a tracheostomy tube. We also did a fundoplication, gastrostomy was also put. And finally, the baby was discharged and 125 day of life. Now, what do you expect for the outcome from such a baby? The parents are happy, the baby is alive. The baby was maintained on oxygen for 2 years of life, which was gradually tapered off. These are the previous slide has come here. And at a follow-up of 6.5 years, the baby is quite fine, speaking well, even singing songs. And there doesn't seem to be any neurodevelopmental delay. There was a delay initially, but he is now picked up and he's absolutely fine. He also has a younger brother with him. So you can hear his voice. Despite tracheostomy, his voice is quite normal. This was a case of bilateral CDH, which is a very rare defect and comprises of only 1% of the CDH cases. Most of them die in utero with a high mortality of 65%, only less than 35% survive. So this was our first survival of a bilateral CDH at our institute. So another baby here, this was done only 4 months back. A baby with CDH, left side defect. And here the sac was so huge, it was reaching up to the thoracic inlet. Post-operatively, the baby started having bilious output. So here again, there are certain things which are not so common, but you have to look for them. We suspected malrotation, got a dye study done, and the baby did have malrotation. A laparotomy was done. and the LADS bands were released. This was the operative finding during the CDH sac. So post-operatively, the baby did well after reduction of the malrotation. So though malrotations are there in most of the cases of CDH, we do not see them to be symptomatic as such, and no surgeon goes out looking for them, but there should be a suspicion of malrotation always in CDH patients, and volvulus may be up to the tune of up to 5%. This was another baby which we operated just 4 days back, last Saturday, in fact. So here you can see this baby came at 2 years of age with a large, with so much herniation of the intestines into the chest. I have a small video, if time permits, I'll show that here. This was done thoracoscopically. So here you can see the contents are being reduced. What I want to show here is, you see this structure here?
We are not able to see the video, Dr. Shilpa.
Not able to see.
Is it part of the presentation or is it separately? Then maybe you can stop there and then share.
Okay. Can you see it now?
Yes, you can see it now.
Okay, so if you can see, this was a contents of the intestinal contents there being reduced. And if you can see this structure here, this, to us, it appeared to be a spleen, and we thought these are adhesions. So we reduced it, we took out the adhesions, and later on, as you see this structure, it starts getting filled up with air. So this was basically the lung which had remained for 2 years in a non-expanded state. So later on, you can see that it starts, the color starts changing. Here you can see maroon and the yellowish hue coming up. Sorry, I didn't edit the video because it was just taken a few days back. So here you can see the lung gets inflated in the end. So this just to highlight that even if the lung is not inflated, up to 2 years of age, the baby was doing quite okay with no signs of respiratory distress, only mild URI, which was diagnosed by the pediatrician, and an X-ray was taken and a CDH was discovered. So CDH is not such a bad anomaly. It all depends from case to case. Thank you. I'll stop here.
Thank you very much, Dr. Shilpa, and it was really very enlightening to hear your talk, and very heartening to know that good hands, CDH has very good outcomes. Important that such a wonderful team in place, beginning with the fetal medicine specialist, obstetrician, the neonatologist, and the pediatric surgeon. So thank you so much for sharing your experience with us.
Thank you.
So may I now request Dr. Vandana, my colleague and my co-coordinator, to, if there are any questions, and take over from here, please.
Thank you, Dr. Sumitra. I think we've answered all the questions in the chat box. If anyone is, any question is unanswered, we'll be happy to take it later for shortage of time, I think. And I would take this opportunity to thank the core team of Society of Fetal Medicine, our esteemed mentor, guide, and the spirit behind this boss called the Society of Fetal Medicine, Dr. Ashok Khurana, who never ceases to amaze me with his innovative ideas, and Dr. Gopal Krishna, who has held our hand and taken us through this webinar. And I also thank all our esteemed faculty, Dr. Nirja, Dr. Vivek Krishna, Dr. Thomas, Dr. Piraju, Dr. Shilpa. I think it's been amazing to have your expertise and all the wonderful ideas that we've shared on this platform. And I want to thank Dr. Sumitra for all her concentrated efforts throughout the month in trying to organize this webinar. And I should also like to thank the audience who've been here patiently waiting and listening even till this late hour. And last but not the least, I would like to thank the backstage team of the Society of Fetal Medicine, Mr. Vishal and Mr.
Yes.
Sir, I can see you there. Okay.
FNB fellows who have really risen to the occasion and done really well. So, Dr. Sumitra, I must congratulate you especially for that. And it's been a wonderful session. I think we've really learned from it.
Thank you. I can see Sir there, but I don't know how busy he is.
Well,
like...
I was supposed to be busy, but I heard such a brilliant webinar. I couldn't take my eyes off. I couldn't shift away. And I really wish to congratulate every one of the speakers for enlightening us this evening. And this is certainly going to be a gem of a collection for the Society of Fetal Medicine. Congratulations to the entire team.
Thank you, sir. You're very kind.
Thank you, sir. Thank you, sir. So, thank you and good night. I think we'll take your leave.
Your permission to close the webinar. Thank you, everyone. Good night, everyone.
Good night. Good night, everyone.
Good night.
Good night.